छोड़ ठीक है ठीक है प्लीज।
बस
कॉल आएगा तो बस आके बंद देखना पड़ेगा।
ठीक है। ये वाला कैमरा देखते हैं तो वो लाइव होगा देखिए। शेयरिंग कर दो सर।
शेयरिंग ऑन कर दीजिए शेयरिंग। शेयरिंग तो ऑन है।
आता ना ये
स्क्रीन शेयरिंग कर दे रहा हूँ ना।
हाँ चल रहा है चल।
ये
हमारी शेयरिंग मत करिए, हमारी शेयरिंग मत करिए।
कर दीजिए, मतलब म्यूट कर दीजिए।
स्टॉप शेयर।
ठीक है। और क्या बोले रिकॉर्डिंग ना।
हम करेंगे, रिकॉर्ड कर देंगे। अभी रहने दीजिए, अभी रहने दीजिए।
ठीक है
कर
सर।
देंगे। ये
शेयर हो रहा है ना आसिफ सर? हेलो। I think you're on mute.
हेलो हितेश।
सूरज
हाँ, now I can hear you.
1 2 अच्छा आप नहीं हुए
नहीं, मैं भी चला जाऊंगा।
स्क्रीन शेयर हो रहा है?
हाँ करो एक बार। हाँ शेयर हो रहा है।
तो चेंज हो रहा है कि चेंज नहीं हो रहा है?
चेंज कर दो। नेक्स्ट पे जाओ।
हाँ,
वो नीचे, हाँ
हो रहा है ना?
हाँ हो रहा है।
परफेक्ट।
नहीं हुई है ऐसे क्यों?
क्या हुआ?
कोई एंट्री नहीं।
लास्ट एंट्री हुई थी ना, दे दो। म्यूट 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 म्यूट।
पूछ लेते ना if he's ready.
करो ready. He's ready.
ठीक. Welcome to Mahamana case discussion series. Good evening, everyone. And today, let's begin our Mahamana case discussion series with a guest talk by Dr. Hitesh Singhvi. He is a senior consultant head neck surgical oncology from Fortis Healthcare, Mumbai. And he's going to give a talk on carcinogens in head and neck cancers and its hereditary predisposition. So you can start now.
Thank you, Sunanya, and thank you, Dr. Asim. At the outset, I would like to thank Mahamana team and entire organizing team for giving me the opportunity to talk on the carcinogens and head neck cancers. I think residents are very excited always on Thursdays to see a lot of case discussions around the world, and this definitely helps them to through their maybe viva or examination, even through the real case scenarios. So without much further ado, I would like to share my screen. Let's see if it works. Yeah, so is the screen shared?
Yes.
Yeah. So let me start with carcinogens in head and neck cancers. Now, what is carcinogen? Carcinogen is a substance, it's an organism capable of causing carcinogen is a substance, organism, or agent capable of causing cancer. Carcinogen may occur naturally in the environment like sunlight or certain viruses, or may be generated by humans like tobacco smoke or exhaust fumes. Most carcinogens work by interacting with cells' DNA to produce mutations. There are over 500 substances which has been identified as definitive, probable, or possible carcinogens for humans. Out of those, 132 agents have sufficient evidence for being carcinogenic in humans, while rest have limited evidence. So according to International Agency Research for Cancer, the agents have been classified into 3 groups. Group 1 is where there is sufficient evidence to suggest that the agent will cause cancer in humans. They are 132. Group 2A are those agents which are probably carcinogenic. That means there is limited evidence to suggest that they can induce cancer in humans. While in 2B, that they are possibly carcinogenic, there are only cases and case reports about them, and group 3, which are not classifiable. So today we'll stick to group 1 and group 2A, and we'll stick to the carcinogens in head and neck. And also in group 1, we'll majorly discuss about the 5 most common carcinogens, that is tobacco, alcohol, areca nut, HPV virus, and EBV virus. Just for your information, the group 1 consists of tobacco, alcohol, areca nut, HPV virus, EBV virus, asbestos, wood dust, and formaldehyde as a carcinogens classified as group 1 for head and neck cancers, while group 2A is gamma radiation, bitumen, that is acetylene to work, radioactive iodine, and opium consumption. So let's start with tobacco. Yes, in last series, Dr. Arjun gave a long talk about tobacco. I'll just wrap it up with 5 slides. I'll just give an overview on how I will take you through the carcinogens. First, I'll give you some information about the carcinogen. Then I'll tell you about the mechanism of action or pathophysiology of that specific carcinogen. Then we'll have a little more information on the prevalence and epidemiology and why that carcinogen is important in global and Indian scenario, and what are the current evidences to suggest that is a carcinogen to humans and especially head and neck cancers. And fifth will be the impact on the presence of that or the carcinogen driven cancers as compared to those which are not driven by those carcinogen. So let me see. First, we start with tobacco. Tobacco products are cause a variety of cancers. There are more than 60 carcinogens in cigarette smoke and at least 16 carcinogens in smokeless tobacco or unburned tobacco. Among these tobacco-specific nitrosamines, NNK, NNN, that is nitroso-nor-nicotine, and polyaromatic hydrocarbons seem to have an important role in cause of cancer, and DNA adducts are central to carcinogenic process as induced by tobacco product. Now, just to take you through the flow diagram, when any individual consumes tobacco and inherently consumes 60 carcinogens while smoking and 16 while smokeless tobacco, they lead to metabolic activation, leading to formation of metabolites, we call as tobacco metabolites or tobacco specific nitrosamines. They form DNA adducts. Majority of these cells or DNA, they undergo repair and therefore they are back to normal DNA. But few, they undergo apoptosis, and very few, they undergo mutation in RAS and TP53 gene, leading to loss of normal growth control mechanism, leading to cancer. While the other pathway is through tumor promoters or gene promoter methylation, leading to tumor suppressor gene inactivation and enhanced carcinogenicity. So this we saw was mechanism of action of pathophysiology. Then we move on to the why tobacco is so important is because according to GATS 2 survey conducted in 2016, 21% of all the adults, 29% males, 13% females, they consume smokeless tobacco. 9% is only smoke and 5% they do both. Therefore, this carcinogen for us, especially in Indian scenario, becomes very important. Now, what are the evidence to suggest? Suggest that smoking tobacco, combustible tobacco, can cause cancer or head and neck cancer, and what are the differential odds ratio of different sites of head and neck cancers. Now, if you take a upper aerodigestive tract, the meta-analysis says it has 3.5 times relative higher risk of those individuals who consume combustible tobacco, who use combustible tobacco, as compared to others. It is 2 times for nasopharynx, 6.7 times for pharynx, and 7 times for larynx. While for smokeless tobacco, it is 4.72, it is almost 5 times that an individual who consumes smokeless tobacco has chances of causing oral cancer. Now, what are the fifth part we come on to? What is treatment-related complication of the carcinogen is current or former smokers who undergo major surgeries are 6 times more likely to experience post-operative complications and have longer hospital stays than never smokers. Higher cotinine levels in these patients who undergo free flaps are associated with increased wound complication rates. And serum cotinine levels. For example, if you want to know how much the individual or the patient is consuming tobacco, apart from his memory, we can use the urine as a sample, and the cotinine levels in sample, that is the metabolite of tobacco, will help us understand the exposure of the individual to tobacco. So next, we move on to alcohol. Alcohol again is a group 1 IARC classified carcinogen. It's a common term for ethanol or ethyl alcohol, a chemical substance found in alcoholic beverages. According to National Institutes of Alcohol Abuse and Alcoholism, a standard alcoholic drink contains 14 gram or 0.6 ounces of pure alcohol. Generally, this amount of pure alcohol is found in 12 ounces of beer, 8 to 10 ounces of malt liquor, 5 ounces of wine, and 1.5 ounces or a shot of 80 proof distilled spirits. Now, consumption of alcohol, as I have already told you, is a group 1 carcinogen. That means there is sufficient evidence to say it is carcinogenic to humans. Next part of the carcinogen is we move on to the mechanism of action. Alcohol or ethanol, it interacts with alcohol dehydrogenase to form acetaldehyde, which in mitochondria forms acetate. Acetaldehyde inherently is a group 1 carcinogen. That means there is sufficient evidence to say it can cause cancer in humans, while the other way is through formation of reactive oxygen species through CYP2 enzyme and catalase. And the acetaldehyde leads to DNA mutations and protein adduct formation, leading to inflammation, leading to activation of hallmarks of cancer, while the other way is through CYP2E, reactive oxygen species, leading to lipid peroxidation, DNA adduct formation, and again, increase in hallmarks of cancers. Now we know what is the mechanism of alcohol carcinogenesis. Now, why it is important for India or global scenario is, even in India, on an average, 29% of all the men, they consume alcohol as compared to female, which is only 1.2%. And you see the Indian map and the dark spots, the hot spots, which is on the eastern part of the country, right from Kerala, Tamil Nadu, Andhra Pradesh, Orissa, and northeastern states. They have higher average drinking population as compared to the other states. Now, what are the evidences? There are enough international evidence to suggest that any type of alcohol drinking, it is mild or moderate or heavy drinking, has higher chances of causing cancer. Now, if you see, the relative risk of light drinking is 1.13 and to 5.13 in heavy drinking, and that is specific to oral cavity and pharynx. And even in Indian studies, in Indian scenario, the odds ratio is 2. That means the individual who consumes alcohol has higher chances, 2 times higher chances of having oral cancer as compared to others. And as far as summation is concerned, whether the individual who consumes tobacco and the alcohol, there is no summative effect, there is a multiplicative effect, and that is evident in even literature. Now, the next slide we come on to is dependent or is focused on the duration and intensity of alcohol. Now, if you see, the patients with oral cavity cancers who were current drinkers drank higher intensities, but not for longer period of time. That means the intensity makes plays an important role in causation of oral cavity cancer, while in hypopharyngeal cancers and laryngeal cancers, the drinking habit shows higher intensity and longer duration, while the proportion of never drinkers was much lower amongst patients in oropharyngeal cancers. Just a fun fact is, we all know that the quit rate of tobacco is low, but especially in the individuals who have underwent surgery, chemotherapy, or radiotherapy, or any kind of treatment, the quit rate is very, very high. But alcohol as a carcinogen, the studies have shown that after 24 months of survival, the individual who was drinking alcohol gains the same percentage after 24 months of survival. That means it's very important that you follow up, when you follow up the patient, especially those who had a habit of alcohol, should always follow up the patient asking for the habit, because majority of them, they revert back to the alcohol habit post-treatment. Next, we move on to the areca nut. We have seen tobacco, we have seen alcohol. Now we move on to areca nut. Areca nut is also a group 1 human carcinogen defined by International Agency of Research on Cancer. Consumption of chewing areca nut is found on the fruit of Areca cashew tree. It is a cultural habit in tropical countries of South Asia, Asia Pacific region. It is the 4th most consumed psychoactive substance in the world, with more than 600 million users. Areca nut extract is composed of saccharides, polyphenol, and for us, most important is alkaloids and some crude fibers and rare tannins. Now, why did I say most importantly alkaloids? Is the alkaloids like arecolin, arecidin, guacolin, and guacinine, which are contained in the areca nut, they are majorly responsible for carcinogenesis. Arecolin is a prime component which causes systemic effects like neurotoxicity, dependency, hypothyroidism, and infertility. It also causes carcinoma in oral cavity, pharynx, esophagus, and others. While arecidin forms major metabolites which are found in urine. Therefore, if you want to measure the exposure of areca nut to the patient, the major metabolites of arecidin will help you understand the exposure of areca nut to the patient. Similarly, other alkaloids, they play an important role in creating differences or problems in epithelial mesenchymal transition area. It causes hypoxia and even formation of reactive oxygen species linked to activation of hallmarks of cancer. Now, areca nut not only causes cancer, it also causes other oral potentially malignant disorder called oral submucous fibrosis, which is more common in Indian scenario. What happens is because of constant chewing and microtrauma, there is chronic inflammation, activation of T cells and macrophages, leading to pro-collagen gene activation, leading to increased collagen production and decreased collagen degradation, leading to formation of collagen bands submucosally, and also in addition to the alkaloids, which we have already seen the carcinogenic effects, leads to increased fibrosis and leading to irreversible mouth opening called oral submucous fibrosis. Now, why are we concerned about the areca nut? While in Western scenario is not even a mention of areca nut in Western scenario, is because according to GATT survey conducted in 2016 and 17, we have seen that apart from tobacco, 8% of the entire population, which ranges from 0.2% in Kashmir to 26.6% in Maharashtra, Uttar Pradesh, the usage of areca nut is variable, but on average, at least 8% of Indian population, they consume tobacco, and that is the reason why it will have its own consequences. Here you see the consumption of areca nut. On the left side is for men, on the right side is for females, and there you will see the highest consumption for men is in Uttar Pradesh, while in female it is in northeastern states. Now, what are the evidence to say that areca nut is a group 1 carcinogen for head and neck or oral cancer? Is an article published in 2014 Journal of Cancer Epidemiology, meta-analysis. It says that areca nut with tobacco has a relative risk of 7.1, odds ratio of 7.1. That means those individuals who consume areca nut with tobacco has 7 times higher chances of developing oral cancer. But this is not the end. Important is this slide, where even areca nut without tobacco, with good number of cases, more than 4,500, and good number of control for comparison, have odds ratio of 2.8. That is, it has 2.8 times higher chances of having oral cancer only with areca nut without tobacco for development of oral cancer. That is the reason why areca nut has been classified as class 1 or group 1 carcinogen. Now, we have seen what is an impact of tobacco is. Now, what is an impact of areca nut on oral cancer treatment outcome? I would say there is no impact, but we can find a weak link where article was published in 2017 by Pankaj sir, which said that oral cancer patients with oral submucous fibrosis in background, may it be an early stage or advanced stage, they have better prognosis as compared to those patients who are only oral cancer patients with no OSMF in background. And OSMF majorly is because of areca nut, and therefore it can be said maybe a weak link. Of course, there is a lot of studies to be found out that whether areca nut plays an important role in better prognosis, or especially in oral cancer patients, whether they fare better. Next, we have gone through 3 important carcinogens, right from the tobacco, then to alcohol, then to areca nut. These were substances. Now we move on to the viruses. First is HPV virus. HPV is also classified as group 1 human carcinogen. In HPV, type 16 and type 18 are group 1 carcinogen. That means there is sufficient evidence to prove that it can develop cancers in humans, while in type 31 and 33 are probably, it is group 2A, probably carcinogenic to humans, while some types are group 2B. Infection with human papillomavirus are common and transmitted by direct contact. Although great majority of infection they resolve within 2 years, 13 phylogenetically related sexually transmitted HPV genotypes, notably HPV 16, is a root cause of cervical cancers, more than 90%, large fraction of anogenital cancers, and increased proportion of oropharyngeal cancers if not controlled immunologically or by screening. So here is a mechanism of or pathophysiology on how the HPV carcinogenesis works. Is HR is a high-risk human papillomavirus. They enter the basal layer of epithelium once infected. HPV infection or HPV virus have proteins they're termed as E1 to E7. E1 and E2 are responsible for infection in the epithelium, while E1, E2, 4, 5, 6, 7, they replicate after persistent infection. After replication, they form or they dispense HPV assemblies and they release it in the another epithelium, leading to capsid synthesis, virion assembly, and virion release. Now, these proteins are of great significance during HPV infection. Now, what happens is when there is persistent infection, the epithelium undergoes hyperplasia and then leading to dysplasia and leading to cancer. Now, at molecular level, E6 and E7, they're very important protein because they block the receptors of P53. E6 block the receptor of P53, and E7, they block the receptor of PRB. That is, they inactivate the tumor suppressor gene, leading to uncontrolled cell proliferation, leading to cancer. Now, even the treatment of HPV-associated cancers are based on this pathway, right from vaccines to gene editing to immune checkpoint blockade therapy to adaptive cell therapy to chemotherapy and radiation. Now, why HPV is important in Indian scenario, but more often Western scenario? Now, which are the HPV-driven cancers? In males, it is oropharynx, penile, and anus. While in females, in addition to this, vulva, cervix, and vaginal cancers. In Western scenario, the HPV-driven oropharyngeal, because since we're discussing head and neck cancers, HPV-driven oropharyngeal cancers are to the tune of 50 to 70%, while in Indian or South Asian scenario, it is somewhere between 20 to 40%, because we have much more usage of tobacco in the form of smoking and smokeless tobacco as compared to Western population, and therefore Western population have higher HPV-driven oropharyngeal cancers as compared to Indian population. Now we all know this article published in NEGM in 2010 by Kianang, which says that the oropharyngeal cancers which are driven by HPV have better survival as compared to those which are not. In Indian scenario, therefore, oropharyngeal cancers have poor survival as compared to the Western population. In fact, they have classified into 3 types. This paper has classified the HPV into 3 types: low risk, intermediate risk, and high risk based on the HPV positivity. This paper also says that even P16 expression, which is a type of detecting HPV infection, is an independent marker to say whether the individual who is HPV positive will have better survival as compared to others. Next, we move on to the EBV carcinogen. EBV is Epstein-Barr virus, again classified as group 1 carcinogen. Virus is linked to 1.5% of all the human malignancies, 1.8% of all the cancer-related deaths, including Burkitt lymphoma, Hodgkin's, and especially for head and neck is nasopharyngeal carcinoma. Nasopharyngeal carcinoma and gastric carcinoma accounts for 82% of all the EBV attributed malignancies and 89% of deaths attributed to EBV associated neoplasm. EBV is known to cause lifelong persistent infection asymptomatically in over 90% of the global population. This number is of the Western population, but yes, majority of them, they have EBV infection, and prevalence of EBV is 100% in type 2, that is non-keratinizing, and type 3, that is undifferentiated nasopharyngeal carcinoma, which is predominant in certain endemic areas. EBV or Epstein-Barr virus subtypes like BAL, CCT, and CT are high-risk subtypes for nasopharyngeal carcinoma. Now, coming to the mechanism of action and how the EBV carcinogens work is, certain individuals, they are susceptible to EBV infection. They have EBV infection-associated genes. They have HLA polymorphism and X chromosome linked genetic susceptibility, which leads to early life exposure to environmental factor and early life infection. That leads to genomic alteration of LOH chromosomes, especially at 3p and 9p, overexpression of certain enzymes. And then over the period of latency period, where the normal nasopharyngeal epithelium converts to pre-invasive lesions, there are EBV modulations like genetic epigenetic aberrations, immunomodulatory tumor microenvironment, and dysregulated signaling pathways, leading to the clonal expansion of EBV infected cells and activation of cancer hallmarks, leading to nasopharyngeal carcinomas. Now, as we have seen of HPV, even in EBV, the outcome is different, though the numbers are very small for non-EBV type 2 and type 3 nasopharyngeal carcinomas. But there is, I would say, the p-value is not significant. But yes, the EBV infection, they fare better. The outcomes are better as compared to those who are not. And key points about EBV-associated nasopharyngeal carcinomas in India is they have high prevalence in northeastern states, especially Nagaland, have considerably high incidence of EBV positive nasopharyngeal carcinomas compared to the other parts of the country. And therefore, when the patient comes from that area, you should have that in the back of the mind. Studies have shown a high percentage of nasopharyngeal carcinoma cases in India associated with EBV often exceeding 70%. Both type 1 and type 2 strains have been identified in Indian nasopharyngeal cancers cases, and non-keratinizing undifferentiated carcinoma subtype of nasopharyngeal carcinoma is most commonly linked to EBV infections in India. So to summarize, group 1 and group 2 carcinogen and what are the sites of impacted in head and neck is in oral cavity, acetaldehyde associated with consumption of alcohol beverages, even individual acetaldehyde or alcoholic beverages. Third is butyl quid with tobacco or without tobacco, that is areca nut. Human papillomavirus 16, tobacco smokeless, tobacco smoking. They are group 1 carcinogen for oral cavity. For salivary glands, it is acetaldehyde associated with consumption of alcoholic beverages and gamma radiation. For pharynx, it is human HPV 16. For tonsil, again HPV 16. For nasopharynx is Epstein-Barr virus, formaldehyde, and wood dust. While for pharynx all combined, these are very common: acetaldehyde, alcohol, butyl quid with tobacco, and tobacco smoking. While the agents with limited evidence in humans, they are bitumens, that is an asphalt to work emissions, occupational exposure to oxidized bitumens and their emissions during roofing. Human papillomavirus 18 for oral cavity cancers, radioactive iodine including iodine 131 for salivary gland, asbestos, bitumens, opium consumptions, and tobacco secondhand smoking. They are classified as group 2 carcinogens for pharynx. I think I end my talk with this, that I may not have covered all the carcinogen, but I think majority of the cancers which are carcinogen driven, we have tried to cover into 5 types, talking about the carcinogen, talking about the mechanism of action, what is their epidemiology and prevalence in Indian global scenario, what is the evidence to say that they are group 1 carcinogen, and what is the impact on treatment. Thank you.
Thank you, Dr. Hitesh, for your comprehensive and insightful presentation on carcinogens and head and neck cancers. And we also request you to join us as examiners for our upcoming case presentation on oral cavity cancer. So today's case presentation will be by Dr. Rukmini Prabhu. She is an MCH resident from PMH Mumbai. And I would like to introduce our examiners for today. Dr. Arvind Krishnamurthy, sir, he is a professor, Department of Surgical Oncology, Cancer Institute, Adyar. Dr. Apurva Garg, he is a senior consultant from CHL Hospital, Indore. And Dr. Lakshmi Narasimhan, he is an associate professor, Department of Head and Neck Surgical Oncology, Sri Ramchandra University, Chennai, and Dr. Sasi Krishna. He is an associate professor, Department of Head and Neck Surgical Oncology, HBCH RC, Vizag. Welcome, everyone. And Dr. Rukmini, you can start your case presentation now.
Am I audible?
Yes, you're audible.
So, coming to the case, My patient is a 49-year-old gentleman. He is a resident of Bhanduk, Mumbai, and he is an auto driver by profession. He came to us with chief complaints of a growth over the inner aspect of the lower jaw on the left side since 2 months, with associated swelling over the left side of the chin since 15 days. The patient was asymptomatic 1 month ago when he noticed a growth over the inner aspect of the lower jaw on the left side, which was initially small and has gradually progressed to the current size. The growth is associated with pain, which is dull aching in type, moderate in intensity, localized to the site of the growth, not radiating. It is aggravated on chewing and it is relieved with over-the-counter analgesics. It is associated with occasional bleeding, about 3 to 4 drops that resolves spontaneously. It is associated with swelling over the chin area on the left side since 15 days, which was initially small and has gradually progressed. And the growth is associated with history of difficulty in chewing. There is history of loosening of teeth. There is no history of reduced mouth opening. There is no history of burning sensation in the mouth or increased sensitivity to spicy food. There is no history of numbness or altered sensorium over the lip or chin area. There is no history of ear pain. There is no history of difficulty in swallowing or change in voice. There is no history of cough, bone pain, abdominal pain, or significant weight loss. Past history, the patient does not have any comorbidities. There is no previous history of cancer. The patient does not have any allergies, and there is history of surgery for a right arm fracture 20 years ago. Coming to the personal history, the patient gives history of chewing tobacco along with areca nut around 10 to 12 times per day since 20 years, and he stopped since 1 month. There is no history of smoking tobacco. There is no history of any alcohol use. The patient consumes a mixed diet, and bowel and bladder habits are regular. To summarize, my patient is a 49-year-old gentleman with no comorbidities, with a history of chewing tobacco since 20 years, with areca nut, with history of a growth over the inner aspect of the jaw on the left side, associated with bleeding, pain, and loose teeth, and associated swelling externally since 2 months. Shall I continue?
Yes, please continue.
You have a clinical picture of it?
Yes, sir. I have it in the examination, sir.
Okay. Yeah.
I will come to the examination.
Yeah, okay.
The performance status of my patient is ECOG 0. He was conscious, cooperative, and oriented to time, place, and person. His height is 166 centimeters and weight is 55 kgs, and BMI was 19.9 kilograms per meter square. And there was no pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy, or edema. And the systemic examination was within normal limits. Coming to the local examination, externally, there was a diffuse swelling over the chin area on the left side, about 3.5 cross 3.5 centimeters, and the skin over the swelling looks normal. The mouth opening was the 4 finger breadths, and the inter-incisor distance was 3.8 centimeters. The orodental hygiene was poor and the teeth were tobacco stained. There was halitosis. The tongue protrusion and mobility are normal. There was an ulceroproliferative growth about 3.5 cross 3 centimeters involving the lower alveolus on the left side, extending from the lateral incisor to the first molar, involving both the lingual and the buccal aspect of the alveolus. The floor of the mouth is free, and the rest of the oral cavity and oropharynx examination on inspection was normal. Coming to palpation, inspectory findings were confirmed with respect to the extent of the lesion, and the induration on palpation was limited to the extent that was seen on inspection. There is tenderness over the growth, and it bled on touch. The involved teeth were loose, and there was no loss of sensation over the lip and chin area. The skin over the swelling is not pinchable, and it was indurated on palpation, and the rest of the oral cavity was normal on palpation. On the neck examination, there was no swelling seen on inspection. The neck skin was normal. On palpation, there was a left level 1B lymph node palpable, which was 1.5 centimeter cross 1.5 centimeter, firm, mobile, and non-tender. And on Hopkins examination, the larynx, oropharynx, and hypopharynx were normal. To summarize, my patient is a 49-year-old gentleman with no comorbidities, with a 20-year history of tobacco chewing, with an ulceroproliferative growth of approximately 3.5 cross 3 centimeters over the left lower alveolus, with loose teeth and overlying skin not being pinchable and indurated, and one palpable mobile 1.5 centimeter level 1B node.
So Rukmini, what makes you say T4A?
Sir, the teeth are loose, which implies that there might be bone erosion. And also on palpation, the overlying skin is involved, sir. It is not pinchable and likely involved. So that's why I said T4A, sir.
Okay, right. So why did you why did you examine for loss of sensation or the chin? So what's the relevance of it?
Sir, it might mean that there might be involvement of the mental nerve, in which case there might be disease along the mental nerve and inferior alveolar nerve. And I need to keep in mind that there might be perineural spread, and my extension of bony resection might be more than what is seen. So.
Okay.
Hello, doctor. This is Dr. Lakshmi Simanu.
Yes, sir.
First of all, it's a nice presentation. I just wanted to congratulate you. So, do you say this as ulcer proliferative or just proliferative?
It is a proliferative growth, sir, but since it is bleeding and it is more of a proliferative growth, sir.
Yeah, so I would call it as a proliferative growth.
Yes, sir.
Rather than an ulceroproliferative growth. And one more, that there's a lot of skin and soft tissue involvement in the floor of the mouth. So, what is the extent of skin involvement in the anterior floor and the gingivobuccal region? Did you quantify that?
No,
You
sir.
said it is not pinchable, right?
Yes, sir. It is not pinchable.
So what is the extent of, see, when you see in this picture, you can make out a
Yes.
significant soft tissue involvement in the anterior
Yes,
floor.
sir. Yeah, yes, sir. It was the induration might be extending up till here, sir, the midline, sir. As what is seen, as much as it is seen on inspection, sir.
Okay.
Rukmini, Dr. Hitesh here.
Yes, sir.
Did you mention that disease was crossing, because from where we see from the photograph, maybe the angle is different, but the disease crossing the midline, is it?
No, sir.
It is not?
No, sir.
Because I can see the proliferation is beyond the central incisor on the contralateral side.
Yeah, your picture shows that it is crossing, seems to be crossing.
On in the floor, on the lingual aspect of the mandible, it
Yes,
looks like
yes.
it is. Yes, sir. But clinically, it was not, sir.
So how would you check for the involvement of the floor of the mouth based on the movements of certain structures in the oral cavity? Dr.
If
Lakshmi has specifically asked about the involvement of the floor, the extent of the involvement of the floor of the mouth.
if the tongue there might be reduced protrusion and mobility of the tongue, sir, if there is
Absolutely.
extensive involvement of the floor of the mouth.
Because you've already mentioned that you didn't
Yes, sir.
answer when we asked for it.
Yes.
Rukmini, what about the nodal status? You said.
Yes.
So there is a palpable left level 1B lymph node, which is 1.5 centimeters in size, sir.
Because from the picture, it looks like the tumor itself is possibly involving the floor mouth, the submandibular gland. So is this node distinct?
Yes, sir. It's a separate 1.5 centimeter node,
Because
sir.
if you go to the previous picture, it looks
Yes,
as
sir.
if
No,
tumor
sir.
is the tumor coming out like that,
No,
or is
no, sir. This is limited to this growth is not this swelling is not palpable in the submandibular region, sir. There's a separate level 1.5 centimeter node in the level 1B, sir.
Somehow it looks slightly bigger to me. The paramandibular spread also looks bigger. But anyway, we guess we trust your judgment and go by that. Yeah.
So are there any investigations performed to check the contiguity of the primary tumor to the, because that is what Dr. Arvind wants to ask you.
Yes, sir.
Are we doing any investigation, because we already have come to the impression, and impression is clinical radiological TNM.
Yes, sir.
So
I would like to we would get an imaging for this patient, sir. I would like to get a contrast enhanced CT scan of the head and neck and also the thorax, sir.
Yeah. Do you have the images?
Yes, sir.
Yeah. Please run it.
So can you describe the findings, Dr. Rukmini?
Yes, sir. So this is a contrast enhanced axial computed tomography scan showing axial images, sir. And on this, there is an enhancing lesion which is involving the GBS and the alveolus on the left side, with along with bone erosion, sir. And it also looks like I have the bone.
Doctor, you have to tell us the extent of bone involvement,
Yes, I have the bone.
because that's going to make a difference in your management
Yes, sir.
and your reconstructive plan,
Yes, sir.
a lot of things.
So there is bone erosion which is extending from about the midline and up until the first molar, sir. And it also looks like there is a it also looks like there's a pathological fracture, sir.
So
Please.
Dr.
Yeah, sorry, please go on.
So Dr. Rukmini, so are you satisfied with the assessment on CT, or would you like to do any other investigation?
No, I'm satisfied with the assessment on CT scan, sir.
Okay, why MRI for this case?
If this patient has significant marrow invasion, sir, so there might be perineural spread along the inferior alveolar nerve, but
so there is marrow invasion. So there is
yes, sir.
through and through erosion, and the marrow is also involved.
Yes,
But
sir.
why you want to avoid MRI for this?
There is involvement of the marrow, sir, but the inferior alveolar nerve is involved, but the inferior alveolar nerve might be involved, but there is no widening of the mandibular foramen on this one, sir. So it is likely not the perineural spread, even if present, it is not likely extending more superiorly, sir.
Yeah, right. So you can see the marrow involvement is not posterior superior to involve the canal and the foramen.
Yes, sir.
So we can avoid MRI in this case.
Yes, sir.
Doctor, have you done any metastatic workup?
So along with the CT scan of the head and neck, we have also done a CT scan of the thorax, sir.
Okay. So that is normal.
That is normal, sir.
Okay. Thank you.
So Rukmini, when would you like to do a PET scan for oral cancers? So
Sir,
yeah.
sir, in general, for an oral cavity cancer, a non-contrast CT scan of the thorax is usually adequate as a distant metastatic workup, because the chance of an extra pulmonary metastasis in the absence of a pulmonary metastasis is very less, sir. But if there are multiple bilateral neck nodes, if there are neck nodes which are involving the lower levels, then maybe we can consider getting a PET scan, sir.
Yeah, and also a very advanced primary, like a
Yes.
T4B cancer and a very large primary, then also you can do a PET scan to rule out distant metastasis.
Yes, sir.
Yeah.
Rukmini, you mentioned about BMI being 19.
Yes, sir.
So what is the importance of body mass index, whether it has any relevance to the complication or outcome of your treatment?
Yes, sir. So this patient will be undergoing surgery with adjuvant treatment, sir. So he should be able to tolerate the treatment, and also before the surgery, we will need to optimize the patient's nutrition, sir. So that's why we need to know the patient's nutritional status before the surgery, sir, before
Do
any
you,
treatment.
do you follow any kind of pre-treatment nutrition protocol?
Yes, sir. We should rehabilitate nutritional. The albumin level of the patient should be seen, sir.
But currently, you're not following it, correct? Or are we
Yes, sir.
still
Yeah.
doing it? Image? Next slide. So in this case, you will say skin is involved.
The
So
skin over the growth is
so when you can say the skin is involved, or when it is indurated, when it is T4 and when it is not.
in this case, it was not pinchable and there was induration, sir. So it's more likely involved, sir.
So indurated skin is T4 or
It is
involved
involved.
skin is T4.
Involved skin is T4, sir, but I could say the skin is closed, sir.
So what would be your management in this case then?
This patient, I would like to offer surgery, sir. I would like to counsel the patient before the surgery for a segmental mandibulectomy, sir, because of the bone erosion. And it would be an segmental mandibulectomy which is extending from the um, uh, the
How will you classify it?
the So there is a classification by for the mandibulectomy defects. There is a classification by Brown et al, sir, in which 1 and 1C are lateral defects with or without the condyle being involved, and the 2A and 2C, 2 and 2C are hemimandibulectomy defects, that is the canine being involved, and 3 is a middle central segment defect with from canine to canine, and 4 and 4C are extensive resections involving the condyle, the canine, and crossing the midline, sir. So this would in this the resection would be from this is a lateral it would be 2A, sir. It's a lateral defect, but it is crossing the midline. Like
Is
my
it 2A?
resection would probably come at the opposite. Yes, sir.
And how will you see the margins?
There is
How much
also
margins you will take for the bone from the mucosa of or the involvement of mucosal margin?
approximately like 2 teeth on either side, sir, or 1.5 centimeter.
So in this case, your contralateral
Okay,
osteomica
so
will
in this
lie
case, if the floor mouth, it looks like it is coming up till the central incisor, sir. So then my cut would be on the premolar on the right side, and the last molar on the left side, sir.
So second molar on the left side. Is there
Yes,
any current evidence to support that? Paper from TMH on margins of bone according to the mucosal margins. How much should be? It's a paper from TMH only.
1.5.
I think it's Arjun has led that. You
Yes,
should
sir.
read it. It's a very good paper
Yes.
to say how much
Okay.
bone margin should be, especially when the marrow is involved. Especially
Okay.
here we are not employing MRI to get the involvement of marrow.
Okay.
Usage of frozen section in this case.
We can do a frozen section to see the margin, sir, but we have retrospective studies which shows that the rates of margin positivity are similar in cases where frozen section is done as compared to by gross examination by the surgeon alone, sir.
That is valid for marrow. Are you talking about gross examination of
Yes.
the margins by Pankaj sir's paper?
Yes, sir.
Is it?
No,
Does the
sir.
inclusion criteria involves marrow involvement?
No, sir. Yeah.
Then how can you extrapolate that data here?
Yeah. But on by frozen section, we cannot examine the bone anyway, sir. So
Can't you send the marrow for frozen section analysis?
yes, sir, we can send the marrow for frozen section.
Yeah, so atypical cells on frozen section can guide you whether the margins are involved or you need to revise the margins.
Okay. Yes, sir.
Any other method you can use intraoperatively, Dr. Rukmana, for the bone marrow?
I don't know, sir.
Scrape cytology, anything you can do? Effectively, that's also like a marrow thing
Yes,
assessment
sir.
only. Are you aware of any studies of scrape cytology for assessment of margins?
No, sir. I'll read up, sir.
Okay. Yeah, read about it. Yeah.
Yes, sir.
Also, good bleeding cuttings is a surrogate for uninvolved
Yes, sir.
margins.
Okay, sir.
So, doctor, what was the surgery done?
This patient has undergone a segmental mandibulectomy with bilateral neck dissection and a free fibular flap, sir. He has undergone a MND on the left side and selective neck dissection 1 to 3 on the right side, sir.
So, Dr.
Okay.
How will you rehabilitate this patient in terms of from dental point of view? Would you do a primary implant? Would you advise a primary implant or a secondary implant?
I would advise a primary dental implant, sir, actually, because there is adequate time for osseointegration before the radiotherapy can be started, and the patient will get early dental rehabilitation, sir, and the patient will be more motivated also because of that, and also since the entire surgery will be done in one sitting, the costs also will be lesser. The only issue is that the duration of the cost and the duration of the this initial surgery might be more prolonged, sir.
So I feel this patient will end up with lower lip resection And also he has a very advanced primary with extensive skin involvement.
Yes, sir.
So, so losing lip, I think it's not a good idea to do a primary implant, sir.
Okay.
What about the other surgeons? What's your take on this?
Doctor, just wanted to ask you how commonly you do both fibula with implants. How commonly you do it?
Not very commonly, sir. Only in
Yeah, that's
limited
what.
infections
We
without.
don't routinely do it.
Yes, sir.
Even when I was trained, also there was like
We don't, sir.
hardly we see any patients.
Yes, sir.
Okay, so it's not routinely done, but can be done. It's not that it cannot be done, but when you have such a big lesion, such a soft tissue involvement, like as doctor was mentioning that there's going to be a significant soft tissue resection.
Yes, sir.
In all those situations, you can have delayed implants.
So, Rukmini, what is an advantage of doing delayed implants? So, when someone who asks you a question whether you're doing primary or secondary, I think you should give your reasoning on what are the advantages of doing a primary implants and what are the advantages of doing a delayed implant as well. So, as I also agree with all other colleagues that we should do a delayed implant. What are the advantages of doing a delayed implant in this case, if we are doing it?
Yes, sir.
अभी वो
Lesser chances of implant failure, sir.
Absolutely. That is very important, that the chances of implant failure, chances of failure in loading of implants, and 6 months survival. These three are important factors in determining whether you should do implants on primary or after delayed. So, coming back to the previous, I think I just had to ask one question, that you mentioned the disease was not crossing the midline. Then why did we address the contralateral neck? Any specific reason or intraoperative finding or?
It is like you said, I think it is because the disease is crossing the midline in the floor mouth, sir. So, and our cut was also laterally. So and on the scan, the bone erosion is present up till the midline also, sir. So that's why we addressed the contralateral neck, sir.
I think that's what I was trying to tell you even before that. When you mentioned about describing the lesion, it should
Yes,
have been crossing the midline.
yes,
I
sir.
think that is the reason why you address the contralateral neck. So,
Yes,
what are the indicators of doing a contralateral neck dissection had
yes,
it
sir.
been not crossing the midline? So, what are the indicators you would see? What are the prognostic factors which you say, yes, we should address the contralateral neck as well?
So there is a paper from TMH by Dr. Manish Meyer et al., in which they've seen the predictors for contralateral neck metastasis in a lateralized lesion, and in that they've seen that presence of ipsilateral neck nodal metastasis and extensive skin involvement are predictors for contralateral neck involvement. So in those cases, we would address the contralateral. We can address the contralateral neck. So.
How do you know the status of contralateral? In general, what is your thinking of contralateral neck node metastasis? In what percentage would it be there? How do you know it?
In a
Can you quote some statistics on it, like contralateral neck node metastasis? It can come as a potential short note also for you.
Yes, sir.
But from the clinical perspective also, I'm asking. So, what are your thoughts on, like, in this particular patient or any patient? Any
Yes, sir.
ballpark figure you can quote for the incidence of contralateral neck node metastasis, and based on what studies?
There is a study by Dr. Bikramjit et al., sir, in which it was mainly for the tongue, in which tongue lesions crossing the midline, the incidence of contralateral metastasis was up to 29%, sir.
So it all depends upon the stage also, right? So
Yes,
any
sir.
early versus locally advanced, and and whether you address it or not. What about in early cancers? Any thoughts on early cancers? incidence in early cancers not crossing the midline, you may not
Yes, sir.
effectively address it, right? Any thoughts on those particular subset of patients, what the incidences would be like, and how do you get to know that incidence?
Sir, it might be less than like 5 to 10%, sir. And in those cases, if it's like a lateralized early tongue cancer, if we are planning for like a sentinel lymph node biopsy, then that would also show us the presence of any
Correct, correct.
contralateral
So
lymph node
effectively, you will
metastasis.
have to go through the studies on sentinel node sentinel
Sir,
node
in clear, yes, sir.
biopsies.
In clear,
So
yes, sir. In
can you quote in any of these sentinel to node trials what would be
yes,
the
sir.
incidence of contralateral neck node metastasis? Right, say
So
the SEN trial.
in the SENT trial, they did note, I don't remember the exact percentage, sir, but they have seen contralateral neck node metastasis, and uh, I I don't remember the exact
So the
percentage
rates
of
are
the
slightly
contralateral
different,
metastasis that they have seen, sir. Yes, sir.
around 10 to 20%
10
odd,
to,
even
yes,
in early stage cancers you do have. So in some of
yes,
these locally advanced, you're bound to have much more. Of course, in this case it's a no-brainer because it's almost reaching up, as you said, or possibly crossing midline, as we all sort of
yes.
see in this picture. Yeah.
Doctor, are there any other options apart from fibula for reconstruction in such a defect?
Um, the the main principle for reconstruction should be like for like. So a bony reconstruction would be an ideal reconstruction for him, sir. If in any case we cannot give this patient the option of a fibula, then we can consider other bony reconstruction, like say maybe a scapular or parascapular flap, sir.
So any other
Or
options, any other bony options other than fibula?
the iliac crest, the deep circumflex iliac artery flap with the iliac crest, or a
Right.
free radial
Right.
osteocutaneous flap, sir.
Correct,
And also
correct,
very
correct.
rarely maybe a PMMC with a rib, sir.
Correct, correct. Or you can use, sometimes some people use a PMC with a sternum also, essentially.
Yes, sir.
Part of it also. Correct. So you'll have to at least know, though fibula is the most commonly practiced flap, you just know the other options also, no? So it just
Yes,
increases your therapeutic armamentarium in some of these patients when
yes, sir.
supposing, say, the patient is paralyzed or some reason, or they have some vascular abnormality that precludes the fibula for some reason. All those things, these options you'll have to keep in mind.
Yes.
Doctor, just wanted to ask you, is
Yes,
there
sir.
any role for neoadjuvant chemotherapy in this patient?
Sir, in this patient, there is no role for neoadjuvant chemotherapy, sir, because it is upfront, it is resectable, sir. And there is already bone erosion, so there is no role of giving neoadjuvant chemotherapy as an organ preservation point of view also, sir.
So then when will you give neoadjuvant chemotherapy? Is there what is the indication for neoadjuvant chemotherapy in oral cancer?
For neoadjuvant chemotherapy in oral cancers, it can be in case of
Or maybe you can just tell purely for mandibular preservation, because otherwise it will be too broad, no, the topic. Initially tell that, and maybe you can also sort of diversify to other indications also in the context of mandibular preservation.
In the context of mandibular preservation, in the case of buccal mucosa, lower gingivobuccal sulcus cancers, or floor of the mouth cancers with extensive paramandibular disease that precludes a marginal mandibulectomy and necessitates a segmental mandibulectomy, as an organ preservation strategy, we can give neoadjuvant chemotherapy, sir.
So Dr. Rukmini?
As the phase 2 study by Chowkar sir from our institute, we had seen that approximately 44% of the mandibles could be preserved, sir. And also in the study by Lisitra et al. In the role of neoadjuvant chemotherapy, they also saw that there was a lesser chances of mandibular resection in those cases in which neoadjuvant chemotherapy was given as opposed to those that did not receive it.
So what are the response rates of neoadjuvant chemotherapy in the phase 2 study?
I don't remember exactly, sir.
It was 38%. How
Okay.
much was it in Lycitra's paper? It was close to 80%, you know.
Yes, sir.
So can you explain and what what regimen was used by Lycitra, what regimen was used by in the
In the Lycitra study, they used a 2-drug regimen, sir, with cisplatin and 5-fluorouracil. And in our study, we've used a 3-drug regimen with a taxane, platinum, and 5-fluorouracil, sir.
So is it counterintuitive to have a 80% response rate in the Lycitra and a 38% response in this? Can you sort of, any thoughts that you want to hazard to explain this disparity? Because obviously we know that 3-drug is better than 2-drug, right?
Yes, sir.
In all parameters, in terms
Yes,
of
sir.
response rates and DFS and in many other parameters also.
Yes, sir.
So what could explain this disparity? I mean, of course, it's not correct to compare evidence or data from two different trials across two different that were maybe 2 decades apart also. But just
Yes, sir.
to tickle your minds, what could have been? It's a glaring. I can understand 5-10% here, there, and all those things, but the difference is close to about 40%.
I don't remember exactly, sir. I'm just guessing. Maybe the Lycitra trial had more cases that were a lesser stage as compared to our studies, sir.
Yeah, it is. That is one issue, and the second important issue is how do you actually go about with your response assessment? Your radiological
Yes,
criteria and all those things
yes,
are very, very sort of very subjective at times,
yes,
right?
sir.
So,
Yes,
so, so although the response rates were lesser, but in the phase 2 study of Dr. Chaukar, the
yes, sir.
amount of mandibles preservation was higher essentially. So
Yes,
that is the interesting part of the data between these two studies, like if you can compare for mandibular preservation.
yes, sir.
Yeah. Right.
Doctor, if you don't have any plastic backup like this for free flap, is it possible to do any other reconstruction?
We could do a PMMC for this patient, sir. But the lesion is crossing the midline, sir. So ideally would be a fibula, but we could do a PMMC, sir.
Right.
So what would happen if we do a PMMC? Can you describe the cosmetic deformity?
There will be loss of the facial contour on the left side, sir.
Yeah. Can you name the deformity?
Sir, if there is no bony reconstruction on both sides for the mandible, then the defect is called as an Andy gump deformity, sir.
Yeah, correct.
So, Rukmini, can you use plate PMC? What is your experience, or how would you justify using a plate in this case, or not?
I'm not aware, sir. I've never seen also, sir, a plate PMMC.
Rukmini, suppose this patient is a 75-year-old gentleman.
Yes, sir.
So what will you offer in terms of reconstruction? 75-year-old gentleman, smoker, decent performance status.
The performance status is good and he is fit for surgery. We can still offer him a bony reconstruction, sir.
Okay, 75-year-old, do you think he'll withstand a 10-hour long surgery?
It depends on the patient, sir. If the patient's performance status is good and the patient has no comorbidities, and if he's a good fit 75 years old, then I would consider, sir.
Okay.
What are other factors apart from age which you consider while making the patient fit for the surgery or any treatment? Have you heard of any indices?
Charlson's comorbidity index, sir.
Okay, and frailty index, have you heard of it?
Okay, sir. Yes, sir.
Who is Charlson? You know?
Yes, sir. It's a lady, sir. It's Mary Charlson, sir.
Okay, and it was described for what?
Uh,
Correct. I'm happy that you're telling it actually.
their paper, they gave a list of comorbidities and scoring, and which uh, predicts the 10-year mortality with respect to these comorbidities, sir.
Fantastic. It was initially described in breast cancers, then
Yes,
subsequently
sir.
they sort of,
Mm.
so read about it. It's a very interesting paper on the Mary Charlson's thing and then how it's modified. And subsequently, of course, you all use this in what is called as a comprehensive geriatric assessment, CGA.
Yes, sir.
Do you know any scores for CGA?
No, sir. I have not read, sir.
Read about that. That will also
Yes,
be
sir.
interesting.
Yes.
Because I'm sure that now you guys are using it. There are a couple of publications from your institution from that.
I'll read up,
Yeah?
sir.
You have a geriatric oncology clinic, so you can
Yes.
read what they use here.
So, Rukmini, what would be your complete surgical plan in this case?
Segmental mandibulectomy with bilateral neck dissection and free fibular osteocutaneous flap, sir.
So, would you do tracheostomy in this case electively?
Yes, sir, because the
So that
defect
should be
is
the
crossing the
in the
midline.
plan, or
It should be in the plan, sir.
reasons for tracheostomy?
In this, the lesion would cross the midline, sir. So the attachment of the muscles of the tongue on the genioid tubercle will be cut. So there will be a risk of the tongue fallback and airway obstruction, and that's why this patient needs a tracheostomy, sir.
Not always, doctor. You're anyhow going to do free fibula, right?
Yes,
You're
sir.
going to anchor the tongue to your fibula graft. So not always, if you can.
Yes, sir.
If it is going to be a thin flap, if you have a good mouth opening, you can intubate the patient, keep the patient intubated. You assess the flap and then you can extubate the patient. Unless it is a big flap, where tongue is significantly edematous, mouth opening is reduced, short stout fellow. So those are the things where you will have definitive tracheostomy. Otherwise, when you are putting a fibula and then pitching your tongue to the fibular graft, you may avoid, not always.
Okay, sir.
So, Dr. Rukmini, you said fibula flap, but if there is extensive involvement of the skin, so
Yes, sir.
what is your cutoff for double flap? How do you decide that you will be doing a second flap for the skin defect and fibula for the oral defect, or only the fibula for both skin and oral defect?
There is extensive skin involvement and the skin paddle of the fibula will not be adequate, then we might need a double free flap for the
Yeah.
external
So what is the cutoff?
skin.
That we agree that extensive, yes, we require, but then how do you decide on doing a second flap and not?
I'm not aware of the exact measurement cutoffs, sir.
In this case,
Usually
what
the
did
skin
you all
paddle
do?
of the fibula will not get we have done only a fibula, sir.
Only a fibula. No, because from the
Yes.
way you described, you said all that skin. I thought that you're really going to take too much of that skin, so you might require double free flap. That's what I was assuming. But okay.
Rukmi, I discussed earlier, we discussed about the contralateral neck and you pointed about certain papers on the use of frozen section in neck nodes to decide on contralateral neck. Did we discuss on that? I'm sorry, did I miss it?
ipsilateral neck node positivity will be a predictor for contralateral neck, sir. So if the ipsilateral neck nodes
So
are
if
positive
if
on
level 2 is
floor,
positive, would you do contralateral neck?
no, sir.
Level 2 in this case is positive. Would you do contralateral neck?
In this case, I would do, sir, because this lesion, other than the ipsilateral neck node positivity, this lesion is also near the midline, like crossing the midline, sir.
Okay.
So in this case, with the level 2 positivity on the ipsilateral side, I would address the contralateral neck, sir. Otherwise, in a lateralized lesion, level 2 positivity alone, I would not address the contralateral neck, sir.
And would you use frozen section for neck nodes for level 1A to check for contralateral neck? Or if the 1A is positive and frozen, would you do contralateral neck node?
There
If it
is
is
no
not
evidence.
crossing the midline, just crossing the midline. Or reaching the midline, I would say.
I'm not aware of any evidence that is there to suggest that 1A positivity is a predictor for contralateral neck node metastasis, sir, because the lymphatics will not spread through 1A to the contralateral neck, sir.
So patterns of lymph node spread then. What are the patterns of lymph node spread in this case? What is
In
central
this case,
node
there might
for
be involvement of
central node of this
1B,
case of this
1B,
primary?
1B, sir. But in this case, because this lesion is in near the midline, coming to the midline of the lip, this patient might have 1A positivity, sir.
Did you all do an implant for this patient?
No, sir, we have not done implants for this patient.
Oh.
Can you tell us about the adjuvant treatment and further follow-up?
This patient is clinically at T4A, sir. So this patient will require adjuvant radiation. And based on the histopathological reports, sir, if there is margin positivity or extracapsular extension, then we would need to give concurrent chemotherapy in addition to the radiation also, sir.
Okay, suppose the bony margin comes positive on histopathology report. Would you add chemotherapy to radiation?
Yes, sir.
So why not revision of margins?
There is a meta-analysis by Mustafa Bulbul et al., sir, in which they have showed that there is like upfront R0 resection has better survival as compared to R1 to R0, or that is positive margins re-resected to negative margins has a lesser survival as compared to upfront negative margins, sir.
Okay, but I don't think it's on the bony margins.
Yes, sir.
I think it's the soft tissue margins. So many of the cancers might be tongue cancers or buccal cancers, where it's a three-dimensional structure where you don't know whether we had revised exactly at the area of positivity. But in bone, we know where the margin is positive, right?
Yes.
Okay, whenever feasible, we should try to revise the margin, adjust the osteotomies if we can. If not, then give adjuvant chemotherapy.
Yes, sir.
So how would you follow up this patient?
I would follow up this patient after the adjuvant treatment for every 3 months for the first 2 years, sir. And at every follow-up, I would do a clinical examination. And after that, for 5 years, I would follow this patient up every 6 monthly and then annually, sir.
Doctor, can you name the trials after which these adjuvant treatments are given? And do you have any idea about OCAT trial?
Yes, sir. For giving adjuvant post-operative radiotherapy, there was a trial from Orissa by Mishra et al. Sir, and for giving concurrent chemoradiotherapy, the trials were Bernier's trial and Cooper's trial, which were EORTC and the RTOG trials, in which they, in the comparative analysis, they've shown that there is improved overall survival and local regional control with giving chemoradiation in cases of extracapsular extension and positive margins, sir. But in these both of these trials, there was the percentage of oral cavity cancers were very less, sir. So in OCAT trial, which was from our institute, we have done a 3-arm randomized control trial, and the 3 arms were standard radiation with 60 gray 30 fractions as one arm, another arm with the radiation along with concurrent cisplatin, and the third arm was accelerated fractionation radiation, in which they gave the same dose as the standard radiation arm, but over 6 days. And in this trial, we saw that there was no difference in the 3 groups with respect to the overall survival or local regional control. But in some cases, with a combination of high risk factors such as T3, T4, along with multiple lymph node positivity, there was some benefit with giving adjuvant chemoradiation as opposed to radiation alone. So, and the study included around 900 patients. So.
Good answer.
What was an added benefit of adding chemotherapy in Bernier-Cooper trial? Added percentage survival benefit.
I don't remember the percentage exactly, sir.
Yeah, so it is less than 5%.
Were both the trials positive, Dr. Akindi?
Sir, in the RTOG trial, which was the US trial by Cooper et al., they did not find a benefit with respect to the overall survival, sir.
Right. So it is the overall survival is in the combination of trials, or there are subsequently been some meta-analysis. Yeah.
Yes, sir.
So because these are seminal trials, so I think it's more likely that you're quizzed on them.
Yes, sir.
Did these 2 trials have same inclusion criteria, or they're different?
The inclusion criteria were different, sir. In the Cooper's trial, they have included extracapsular extension, positive margins, and more than 2 positive lymph nodes. And in the Bernier's trial, they've included extracapsular extension, positive lymph node margins, perineural invasion, presence of vascular emboli, and lower lymph node levels in oral and oropharyngeal cancers.
Perfect.
Wonderful. Very good.
What is the expected survival for this patient, doctor?
This is a T4A lesion, sir, stage 4A, so I would say around 50%, sir. 5-year overall survival, sir.
50%. What was the nodal status? This was.
This was
has a histopathology of the surgery.
No, we don't know, sir.
So
But
if it is N0, N1, all those things make a difference.
Yes, sir. Presence of lymph node metastasis reduces the survival by 50%, and presence of extracapsular extension reduces the survival by a further 50%, sir.
I think 50% is a bit too optimistic.
Yeah. So generally for a ballpark for a locally advanced, now you can say anywhere between 35 to 40 or something of that sort. Like, no?
Okay.
50
Yes.
maybe if it is N0 or sometimes a bone only disease and without skin and all those things you may get rarely, but
Yes,
anywhere between around 35, 30, 35, 30 to 40, that would be a reasonable estimate.
So TMH has own audit published in Indian Journal of Cancer in 2019. You should read about it. Deepa Nair madam had published it. audit of 5-year oral cavity cancer, operable oral cavity cancer. It is between 50 to 60%.
Okay, sir.
What is the
Again, it's important to understand, sometimes what happens is that, what is the inclusion criteria? Because if you say, as you take all comers, stage for stage, all those things you'll have to go through it and then you'll have to sort of. Okay. So when we say about 35 to 40%, it means stages 3 and 4, all comers essentially. But
Yes.
if you are taking an individual data of all resectable, so like for example, sometimes if you say stage 3, stage 4, if you include the unresectable ones, then your survival dips. But if you're taking the resectable ones, then your survival sorts of, your jacks up or something like that. So again, you'll have to know the inclusion criteria, what has been included, and based on that, you'll have to exactly qualify your answer, basically.
Yeah.
Sorry, somebody was saying something.
Yeah, so I was asking her a question. So what is the annual risk for this patient to develop a second primary? And what would be the common site for second primary?
The annual risk for development of second primary metastasis in oral cavity cancers is around 2 to 7%, sir.
What would be the common site for second primary in head and neck cancer?
For a second primary in the oral cavity, the most common site of a second primary would be in the oral cavity only, sir.
Okay. So can you tell us the Warren and Gates criteria?
Yes,
for
sir.
second
The
primary?
Warren and Gates criteria for second primary malignancy states that both the primary and the suspected second primary should be histologically proven metastasis, and one should not be a metastasis of the other, sir. And
Anything else?
they should be separated by anatomically normal mucosa, sir. But the how much this normal mucosa is different according to different people. Some say 1.5 to 2 centimeters, etc. sir.
Okay, and what should be the difference in duration between the two tumors? 1 year, 2 years?
Well, second primary malignancies can be synchronous or metachronous, sir. Synchronous primary, second primary malignancy would be within 6 months of this one, and metachronous would be after 6 months, sir.
No, many of the others say they should be at least 3 to 5 years
5
difference.
years.
Yeah, and also there should be
For
some
recurrent.
form of genetic profiling. If the histologies are same, there should be a genetic profiling to look at loss of heterozygosity.
Yes, sir. There is a study by Gracchus et al. Which says that if the genetic profile is the same, then it could be classified as a second field tumor as opposed to a second primary tumor, sir.
Right.
No, there are different various definitions. It can also be the same site also.
Yes.
Okay, so again, the distance also. Some studies say 3, some studies say 5.
Yes.
So again, there is no sort of standard definition of what to call a recurrence versus an SPT, a second primary tumor, essentially.
Yes.
Yes, sir.
Good, I think. Did we stop or 7?
Dr. Sunaina, can
Yes,
you
sir.
wind up?
Yes, if the question, I mean, if it's done, then we can wind up here. Any
Yeah,
some more questions, some points to discuss.
questions or yeah,
There will be several questions, but if you want to discuss something, then otherwise we can wind up.
You call us back, Azim, sometime. We will discuss.
Definitely, sir. We'll be calling you back.
Yeah. Anyway, Rukmini, as usual, she's been a veteran. I was asking somebody whether she's already a consultant or something like that because she's been presenting for so long in a way, So anyway, very good. You really are doing very well.
You'll be appearing the examination. I
Very
think
good job.
Yeah.
Thank you, sir.
Okay.
Very good presentation.
Thank you, sir.
Just
Yeah,
take
what-
care of all the publications coming out of TMH.
Yes, sir.
Yeah,
Thank you, everyone.
Thank you.
We'll meet again on 20th of February with another interesting case
Cancers.
on early laryngeal cancer. So,
Thank you.
yeah,
Thank you.
thank you.
Bye bye.
Thank you, sir.